Hello everyone and welcome to our module on drug elimination. Let's imagine that we wanted to understand the pattern that a drug follows as it is eliminated from the body. One way we could do this is to inject the drug into the bloodstream and then monitor the concentration of that drug over time. So let's imagine that at time 0 we inject a drug into the bloodstream. Obviously its plasma concentration will rise up to some high value. We could then follow the concentration over time, and the concentration will begin to fall as that drug is eliminated from the body. And there are two typical patterns that drugs follow as they're eliminated from the body. The first pattern is called zero order. The second pattern is called first order. In zero order elimination, the fall in plasma concentration is a straight line, as shown here. In first order elimination, the fall is a curved line. It's steeper here, and then it becomes less steep as time goes on. And we'll talk about the differences between these two patterns of elimination in the next few slides. In zero order elimination, there is a constant rate of elimination per time. If we look at this graph I've shown on the screen here, every time this much time goes by, 5 units of the drug is eliminated. It's constant, 5 units per unit time. For example, 5 units per hour. The reason we call this zero order elimination is because the rate of elimination is equal to some constant. For example, 5 is the constant in my graph on the screen here, times the drug concentration raised to the 0 power, and anything raised to the 0 power is 1. So this equation says the rate is going to be constant at 5, and it will not depend or vary with the drug concentration. And this is a high yield point to remember. Zero order elimination drugs show a rate of elimination that does not depend on the concentration, and that is different from what we see with first order elimination drugs that we'll talk about in a minute. Drugs with zero order elimination also do not have a constant value for half-life. The half-life is the time required for the concentration of the drug to fall by 1/2, and that number is always changing for zero-order elimination drugs. Let's imagine that we have a serum concentration of 20 milligrams per hour of a drug, and it is eliminated at a rate of 5 milligrams per hour. This means it will take 2 hours in order for the concentration to fall to 10, so that would say the half-life is 2 hours. However, the time to go from 10 down to 5 is only 1 hour. So now you would say the half-life is 1 hour. And then the time to go from 5 to 2.5 would be a half an hour. So now you would say that the half-life is a half an hour. So the bottom line here is there is no single value for the half-life, and the half-life depends on the concentration. If you have lots of the drug in the plasma, then the half-life is relatively long, like 2 hours. If you have very little of the drug in the plasma, like a concentration of 5, then the half-life is shorter. So half-life is always changing depending on how much of the drug is in the plasma. So going back to this slide, these are the key points to remember about zero-order elimination. There is a constant rate of elimination per time. That rate does not depend on the concentration of the drug, and there is no constant value for the half-life. And there are 3 classic drugs that are held up as examples of drugs that undergo zero-order elimination. Those drugs are ethanol, phenytoin, and aspirin. Now let's talk about first-order elimination. In this case, the rate of elimination varies with the concentration of the drug. We call first-order elimination drugs first order because their elimination rate is equal to some constant C times the drug concentration raised to the first power. Therefore, the drug concentration influences the rate of elimination. So if we look at this graph on the screen here, what you can see is it has the curved shape of first-order elimination. When the concentration is high, the rate of elimination per unit time is also high, like 4 units per unit time here. But when the concentration gets lower, the rate of elimination over time falls and becomes lower. So we have a rate of elimination that is varying with the concentration of the drug. Now, even though the rate of elimination, like 4 units per hour or 2 units per hour, varies with the concentration of drug, the percent change is constant. This is the half-life. So the half-life of these drugs is constant even though their rate of elimination is changing over time. Let's go back to our example of a drug with a concentration of 20 milligrams per liter in the plasma. If this drug underwent first-order elimination, then after, for example, 1 hour, if that were the half-life, we would then have 10 units. And after another hour, we would then have 5 units. And after another hour, we would then have 2.5 units. So you can see that the change from 20 to 10 and 10 to 5 is different every hour. However, the percent change is constant, and therefore the half-life is constant. And most drugs follow first-order elimination. There are just a few drugs that follow zero order, and those are the ones I mentioned on the last slide. The boards love to show you data tables and ask you to interpret them. So let's go through what zero order and first order elimination would look like in a data table. So let's imagine at time 0, we have 20 grams of a substance in the plasma. That is 100% of the substance. If we had zero order elimination, for each hour that goes on, a constant amount would be removed, for example, 5 grams per hour. What that means is that the amount remaining in the plasma would change such that we'd have 75% after 1 hour, 50% after 2 hours, and 25% after 3 hours. The key point is that the change per hour is constant and the half-life will always vary. So for example, it takes 2 hours to get to 50%, but then it only takes 1 hour to get from 50 to 25. If we had a drug with first order elimination, it would look like what's shown on the table here. For each hour that goes by, a different amount is removed. There's more removed in the first hour when the concentration is high, and there's very little removed in the third hour when the concentration is low. But notice that each hour that goes by, the amount in the plasma changes by 50%. We go from 100 to 50%, and then 50 to 25, and then 25 to 12.5. This is what first order elimination looks like. A related concept to first order and zero order elimination kinetics are two special types of elimination called flow-dependent and capacity-dependent. So let's talk about these now. Flow-dependent elimination refers to drugs that are metabolized so quickly that blood flow to a particular organ, usually the liver, determines elimination. These drugs are virtually all extracted from the plasma by a particular organ, usually the liver. This means that their rate of elimination is essentially dependent on blood flow. So a classic example of a drug like this is morphine. Morphine exhibits flow-dependent elimination, and this means clinically that patients with heart failure and less blood flow will exhibit decreased clearance of morphine because it has flow-dependent elimination. Drugs with capacity-dependent elimination follow Michaelis-Menten kinetics, which I talk about in the videos on enzymes. Their rate of elimination from the body follows the equation Vmax, meaning the fastest rate of elimination, times the concentration of the drug divided by a Michaelis constant Km plus the concentration of the drug. Drugs with this type of elimination are said to be saturatable because if you have a very high concentration, then they will have a constant elimination rate at Vmax. If you look at this equation, if C is much, much higher than Km, then Km doesn't become important anymore. And then the two C's cancel each other out. And this equation will say that the rate of elimination is equal to Vmax. This means that these drugs will be eliminated at a constant rate, which, as we talked about earlier, means they will follow zero order elimination kinetics. And once again, the three classic drugs that do this are ethanol, phenytoin, and aspirin. At high concentrations of these drugs, which is usually what they have in the body, they will have a constant rate of elimination equal to the Vmax by the Michaelis-Menten equation, and this means they will display zero order elimination. Now let's talk about a very simple but high-yield topic for step 1, and that's how urine pH affects the elimination of drugs. You should know that many drugs are either weak acids or weak bases. So a weak acid is a drug that likes to give up a hydrogen atom. So it's some anion, A, and a hydrogen atom connected together, so we call it HA, and it can fall apart and become the anion plus a hydrogen molecule, like what I've shown right here. Weak bases are something like a base B connected to an OH molecule, and that can fall apart and become a positively charged base plus an OH negative molecule, like I've shown right here. Drugs, like many other things in the plasma, get filtered by the glomerulus and enter the nephron. Recall that the glomerulus filters most things in the plasma, and then it reabsorbs the things that the body wants to hold on to. The high yield point for you to know is that the ionized forms of drugs, that's the form that is positively or negatively charged, gets trapped in the urine after filtration, and it can't diffuse back into the circulation. So if we look at our weak acid equation right here, if the drug is in this form in the nephron, it will get reabsorbed. But if it's in this form, it will be trapped in the urine and go out of the body. For the base, if it's in this form, it will stay in the body and get reabsorbed. But however, if it's in the charged form here, it'll stay in the urine and get excreted. What this means is that the urine pH is going to affect drug excretion because the urine pH can favor either the ionized or unionized form of the drug. Let's talk about the weak acids first. So if you have a very acidic urine, that means you have a lot of H plus molecules present in the urine, and that's going to drive this equation this way because we're going to have so much H plus on this side, the equation is going to go this way and form the unionized form of the drug. This is going to get reabsorbed. So an acidic urine favors the reabsorption of weak acids. For the bases, it's the opposite. If we have a very high concentration of H plus in the urine, those H plus molecules are going to combine with the OH negative to form water. That is going to decrease the concentration of OH negative in the urine, and drive the equation this way. So for weak bases, an acidic environment favors formation of the ionized form of the drug, and that gets excreted. What this means is that we can manipulate the excretion of drugs by altering the pH of the urine. So for weak acids, we want to alkalinize the urine to excrete more drug. In other words, we want to remove H plus from the urine so that we drive the equation this way for weak acids and form more of this A negative, which will get excreted. For weak bases, we want to acidify the urine to excrete more drug. In other words, for weak bases, we want to increase the amount of H plus in the urine. This will favor formation of the ionized form of the drug, and that will go on to get excreted. And the easy way to remember this is just that you want to do to the urine the opposite of the drug. So if the drug is an acid, then you want to alkalinize the urine to get it excreted. And if the drug is a base, then you want to acidify the urine to get more to be excreted. So this does have a clinical correlation in some rare circumstances. There are a couple of drugs that are weak acids. Phenobarbital and aspirin are two of them. And if patients overdose on these, you can administer sodium bicarbonate to alkalinize the urine and increase the rate of excretion. There are also a couple of drugs that are weak bases. Amphetamines and quinidine and phencyclidine are all weak bases. So you can administer ammonia chloride to acidify the urine in an overdose. Now, this is really historical. Nobody does this anymore. And that's because the efficacy could not be established, and there is toxicity associated with causing a severe acidosis in a patient. So nobody really does this anymore. Final topic for this module is drug metabolism. So there are many, many liver reactions that metabolize drugs. And the pharmacology literature is replete with examples of all the different ways that drugs are chemically modified by the liver. But there's a couple that you should know as a medical student. First of all, you should know that the big picture is the liver wants to biotransform drugs into something that's easy to excrete. So they usually convert lipophilic drugs to hydrophilic products. And remember what I said, these hydrophilic products are water soluble and then they can be excreted in the urine. And there are two general classifications for all the different reactions that occur in the liver with drugs, and that is the phase 1 reactions and the phase 2 reactions. So the phase 1 metabolism reactions are generally reduction reactions, oxidation reactions, or hydrolysis. And you don't really need to know the organic chemistry of all this. You just need to know the names of the types of reaction. One thing you should know about phase 1 metabolism is that it often creates active metabolites. So the products of these reactions are usually not ready for excretion, and they're usually still active. In fact, some drugs require a phase 1 reaction to activate them from a prodrug into their active form. Two other key facts to know are that phase 1 metabolism has been shown to slow down in elderly patients. So there does appear to be an age-related decline in the rate of these reactions. And then the second thing that's important to know about phase 1 metabolism is that this includes the very important cytochrome P450 system, which we'll talk about now. The cytochrome P450 system is a collection of intracellular enzymes that metabolize many drugs as part of phase 1. The clinical problem that comes up with the P450 system is that there are many drugs that inhibit or induce it. So you can imagine that patients are often on more than one drug. If one drug's being metabolized by P450 and another drug inhibits that system, it will alter the effects and the levels of that first drug. So if you inhibit the P450 system, drug levels can rise if a drug's being metabolized by P450. If you induce the system, drug levels can fall. So inhibitors of the P450 system are the most dangerous because these can cause drug levels to rise, and this can lead to toxicity. Some important inhibitors worth knowing are cyclosporin, some macrolides, and the azole antifungals. Now, luckily, many of the drugs that are metabolized by P450 are rarely used anymore. So, for example, theophylline and cisapride, which is a GI drug, and terfenadine, these are all drugs that you'll hardly ever see used anymore. So the fact that the P450 system may be inhibited or induced by another drug is not that big a deal since very few patients are on these. There are a couple of clinically relevant possibilities. So I have seen patients on statins who were administered cyclosporin develop rhabdomyolysis. There are also many patients who take warfarin, and if they take an inhibitor of the P450 system concomitant with warfarin, their warfarin levels can rise and their INR can get very high. If you go online and look up a list of inducers and inhibitors of the P450 system, you'll find a huge list of drugs. And this is why we have pharmacists to help us out to make sure we don't have drug interactions. But some that you should certainly know for your boards in terms of inducers of the P450 system: chronic alcohol, rifampin, phenobarbital, carbamazepine, griseofluven, which is a fungal agent, and phenytoin. These can all induce the P450 system. And that means that a drug that's metabolized by P450 can see its levels start to fall and become subtherapeutic. The inhibitors, which remember I said are more dangerous, are drugs like isoniazid, antibiotics like erythromycin, cimetidine, azoles. Grapefruit juice has been described as inhibiting the P450 system, and ritonavir, which is an HIV medication. So if any of these drugs are given concomitantly with a drug that's metabolized by P450, that drug level can rise and potentially the patient can develop toxicity. Now let's talk about the phase 2 metabolism reactions. And these are generally conjugation reactions. They fall under the type of reactions called glucuronidation, acetylation, or sulfation. And once again, you don't need to know the organic chemistry of all these reactions. You should just be familiar with the names. And phase 2 metabolism generally produces very polar inactive metabolites that go to the kidney to get excreted. One place where the phase 2 metabolic reactions have some clinical relevance has to do with patients who are known as slow acetylators. These patients have a genetically mediated decrease in the ability to carry out phase 2 acetylation reactions. Usually this is caused by a decrease in an enzyme called hepatic N-acetyltransferase. So in the pharmacology literature, much has been written about slow acetylators because these patients metabolize certain drugs more slowly. For example, acetylation is the main route of metabolism of the tuberculosis drug isoniazid or INH. It's also important for metabolism of sulfasalazine, which is an anti-inflammatory. So patients who are slow acetylators will metabolize these drugs more slowly than others. Acetylation is also important for the metabolism of procainamide and hydralazine. And you may know that both of these drugs are associated with drug-induced lupus. And because they're both metabolized by acetylation, this has been studied, and drug-induced lupus is more likely in patients taking procainamide and hydralazine if they are slow acetylators. And that concludes our module on drug elimination.